Welcome, everyone. I'm Robert Dubrow. I'm a professor of epidemiology and also the faculty director of the Yale Center on Climate Change and Health at the Yale School of Public Health. And welcome to this Yale Lancet Countdown lunch event. So the Lancet Countdown on Health and Climate Change is an international collaboration that's been monitoring the health consequences of climate change through an annual report that's been published in the medical journal, The Lancet, since 2015. The collaboration includes researchers from 43 academic institutions and UN agencies. And researchers from Yale have been part of the collaboration since 2019. The 2021 report was published in The Lancet this year on October 20th, and that was followed by a global launch event the following day. But subsequently, there have also been regional launch events around the world, and this is one of those regional events. Given the COP26 that was just completed, the 2021 report, which is organized around 5 domains and 44 indicators, was particularly timely in framing the climate crisis as a public health crisis. So today, we're going to have 5 speakers, and I'm going to introduce them now and let you know what they'll talk about. So the first speaker is Marina Romanello, who's the research director at the Lancet Countdown and the first author of the 2021 report. And she's going to give an overview and highlights of the global report. Then Dr. Jodi Sherman, who's a professor here at Yale of both anesthesiology and environmental health sciences, and also the director of the Yale program on healthcare environmental sustainability, will talk about one of the indicators, which is healthcare sector emissions. Then I'm going to talk about another indicator, which is air conditioning benefits and harms. Yeah, so I was introducing Jeremy. He's a professor in the departments of environmental and occupational health sciences, global health, and emergency medicine. And he's also the director of the Center for Health and the Global Environment at the University of Washington. And he's going to give an overview and highlights of the Lancet Countdown US Policy Brief, which was a very important kind of ancillary report that was done in conjunction with the global report. And then finally, Dr. Laura Bosey, who's the director of programs at the Yale Center on Climate Change and Health, will give an overview and highlights of a report that our center did on climate change and health in Connecticut 2020 report that was not associated with the Lancet Countdown, but nevertheless kind of used it as a model in terms of organizing the report around indicators. So without further ado, let me turn it over to Marina. Let's see.
Thank you, Rob. Thank you so much. Let me see if I can share screen. Can you see my full screen there?
Yes.
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 Is that showing? Yeah, awesome. So I'm gonna try to give you a very brief overview of the report and tell you a bit what the Lancet Countdown is. But first of all, I really wanted to thank Yale for hosting this event. As Rob said, Yale is one of our key partners at the Lancet Countdown, so it's really an honor to be here with you. So we are 43 partners around the world. The Lancet Countdown is based on institutions and UN agencies around the world. And as Rob just said, we produce indicators tracking progress on health and climate change across impacts and what the response to climate change means for health. And the data gets published every year in the medical journal, The Lancet. The report that you see in large here is our latest report that is labeled a code red for health. So I'm going to tell you a bit about why that is. But this is just the latest of the series of the Lancet Countdown reports with a 5th year of iterations of this kind of tracking and monitoring exercise. So our report, as I said, is entitled A Code Red for a Healthy Future. And this is because across all of the indicators, we're tracking the impacts of climate change on health. We're seeing trends rapidly worsening and affecting particularly the most vulnerable in every society, in every country, exacerbating in this way the inequities around the world. And when we think about climate change, the first thing that comes to mind is increase of heat waves, increased temperatures. And we're seeing that the very vulnerable population, people over 65 years of age, are increasingly being exposed to life-threatening heat waves. Heat waves are silent killers, they're more than just uncomfortable. And we're seeing very vulnerable groups increasingly affected, as you can see here, mainly starting the year 2010, really rapid increase in exposure to heat waves. And heat waves not only affect our health directly in terms of morbidity or mortality, but they also affect our health indirectly by undermining our capacity to work. We also monitor the extent to which heat exposure is reducing our labor capacity, particularly in the agricultural sector. We're seeing big impacts in terms of hours of labor loss in countries that are very vulnerable, the low human development index country group and the medium human development index country group, seeing particularly big losses, and especially in the agricultural sectors. We estimate that the losses in the low human development index country group amount to 4 to 8% of the total GDP of those countries being lost due to heat exposure. So social determinants of health also being put at risk. And obviously increased heat-related mortality. We've seen the heat waves this year in Canada, in Sicily, in Kazakhstan, and heat exposure is increasing, as is heat-related mortality as well. And with increased heats and increased temperatures, our capacity to grow crops is also reducing. So we're seeing crop yield potential reducing across all major staple crops, anywhere from 3 to 6% of reduction in crop yield potential from a 1950s baseline, which is even getting exacerbated by the increased land area being affected by extreme drought. The percentage of land area affected by extreme drought exposure reached about 20%, a record in 2019. And with dry weather, hot weather also comes increased incidence of wildfires. And in the US, we have been suffering horrendous wildfire seasons as a result of climate change, much of which we have the detection attribution study that pinned down the cause to climate change. And as temperatures change, precipitation patterns change, and humidity changes, so too does the environmental suitability for the transmission of infectious diseases. And we're seeing particular increases in the suitability for transmission of dengue, of malaria, of Vibrio pathogen, Vibrio cholerae, and other Vibrio bacteria as well, all around the world, particularly Vibrio bacteria in the Pacific Northeast and Atlantic Northeast as well. So all of our indicators are flashing red, really raising an alarm to the health risks of climate change. But perhaps the most concerning thing is that not only climate change is exacerbating health impacts, particularly on the most vulnerable, but our response to climate change is also increasing the inequities gap. As we have failed to deliver a just response to COVID-19, we're seeing an unjust response to climate change. The main thing that we need to do in order to reduce the impacts of climate change is obviously to quickly adapt and decarbonize. And when we talk about climate change mitigation, decarbonization, the energy system is essential because it's the main contributor to greenhouse gas emissions. But as you can see in this black line, the carbon intensity of the global energy system, that is the amount of energy, of carbon dioxide produced per unit of energy generated, has not changed practically since the 70s. And at the pace of slow reduction that we've seen from 2014 to 2018, it would take us roughly 150 years to fully decarbonize our energy systems. The other thing that is notable here is that it is the high human development index countries, the ones that are adopting technologies to decarbonize and to benefit from the health co-benefits of a fast decarbonization, whereas the high human development index and the medium human development index country groups are still growing at a carbon intensive way, not benefiting from a low carbon transition. And the low human development index country group still has to do that kind of development and industrialization gap. And what this means for health is that exposure to air pollution is still incredibly high. We have not managed to reduce exposure to air pollution since 2015 significantly. In 2019, we saw roughly 3 million deaths attributable to ambient air, PM2.5 air pollution, the most harmful form of air pollution, and 1/3 of that came from fossil fuels. And as you can see here, this is disproportionately affecting the high and medium human development index country groups that are very carbon intensive. But the low human development country groups is being particularly affected by indoor exposure to air pollution through the use of dirty fuels for cooking and for heating. So also big inequities in the transition to a cleaner source of fuel use. However, there is still some hope that comes from our report, and that's really worthwhile noting. When we talk again about energy system, while we're still lagging behind, we are seeing a very fast adoption, increasing the use of renewable, clean, new renewable energies for energy production, particularly in the US and in China, the biggest contributors to greenhouse gas emissions, which is really positive. Total energy produced from clean sources has reached 7.2% in 2018, and this is still growing. So we do have the technology. And one other thing that is really worth noting is that the health sector that is crucial in protecting our health from climate change, and if we acknowledge that climate change is a health crisis, they must be at the forefront of the fight against climate change. Health sector is now taking the lead, and we've seen many commitments made during COP of national health systems that have committed to reaching net zero by 2050, and over 50 health systems around the world committing to become more sustainable and more resilient to climate change. So just to finish off, a final reflection that comes from our report, but also from what happened at COP26. We are currently exiting the COVID-19 pandemic. And as the world tries to recover, we're enrolling trillions of funds towards economic reactivation and reframing. However, so far we see that only 18% of those trillion, almost $2 trillion allocated to COVID recovery would lead to reduction in greenhouse gas emissions. All the rest will have negative effects on climate change. So we're here at a pivotal point where we have to decide whether we're going to go through a carbon intensive route that will lead us to a new crisis, a crisis of climate change impacts on health, and that will undermine our progress against the Paris Agreement and the nationally determined contributions, or whether the world will act together to deliver a just transition and make use of this moment to deliver a world of environmental sustainability, economic sustainability and growth, better health, and reduced inequities. And with that, I will just close and invite you to visit lancetcountdown.org, where you can explore a bit more of our indicators that I just gave you a very brief overview of.
Thanks very much, Marina. So next we'll have Dr. Jodi Sherman talking about the indicator that she took the lead on.
Thanks. Can you hear me and see the screen okay?
Yes.
So my talk is going to focus on the role of the healthcare sector, its contribution to climate change. Now, as Dr. Romanello was saying, we have increased demands for health services because of the myriad of health impacts of climate change. Healthcare itself is ironically a significant contributor to global greenhouse gas emissions and non-greenhouse gas emissions. We've got a very high resource consumption industry. Hospitals run 24/7, high-tech diagnostic therapeutic equipment, high energy intensive buildings. And healthcare is a unique risk for unique infection risks and prevention requirements that drive a lot of disposability and utilization of resource, both energy as well as materials. We also live in a complex regulatory environment designed to protect our patients and also occupational health. But we also have business models, and that regulatory complexity and business models drive low value consumption of resource. We also, particularly in high income nations, and especially in the US, have a culture of excess and where disposability is normalized. And in healthcare in particular, because we have a social mission to protect individual patients, we've really been neglecting about the impact of how care delivery affects public health, and we can't really do that anymore. So the key results of the Lancet Countdown latest publication, 2021, globally, healthcare emits 4.9% of total global greenhouse gas emissions, and this is rising at a rate of 5 to 6% annually. This is the most, there are several international studies, this is the most recent result. US healthcare is an outlier and not in a good way. We spend twice as much on healthcare as any industrialized nation, 18% of our GDP. Healthcare globally is 10% of the economy. So if we can, not only should healthcare be leading as an industry in health and all policies and protecting public health, because we intersect with so many areas within the global economy, we have the opportunity to help drive change globally. Of that 4.9% emissions, healthcare in the US is responsible for a quarter of those emissions globally, despite only having 4% of the global population. And we have the highest per capita healthcare greenhouse gas emissions. Now, if we have the best health outcomes for that impact, for those expenditures, there might be some justification, at least till we transition our energy sources and our embodied emissions, but that's not really the case. So what we did is we associated per capita healthcare greenhouse gas emissions along with the global burden of diseases, healthcare access and quality index. This is from the 2020 paper, 2021. We did the same association with the Human Development Index and the results are the same. So we want to have as low greenhouse gas emissions per healthcare capita as possible and as high performance in terms of healthcare quality and access. And we can see the highest performers here in Europe, particularly France is a notable outlying performer in a good way versus the US. So not only do we have the highest per capita greenhouse gas emissions, we do not perform the best in terms of healthcare access and quality. We're about 1,700 kilograms of CO2 equivalent emissions per capita for healthcare. Versus 450 in France. So 450 is around the break-even point. The good news is what that means is we can reduce our emissions without sacrificing quality of care. And in fact, 11% of the US population is presently uninsured. You know, about 1/3 of US healthcare resources are deemed low value or inappropriate. It's about 1/4 globally. What that means is that we have room to improve our environmental performance without sacrificing quality of care and preserving resources to improve our access to care. I'm going to shift gears in terms of where this information comes from. In order for us to understand where the levers of influence are, I'm going to turn to the Greenhouse Gas Protocol. This is from the UK National Health Service Net Zero Report. The National Health Service in England is leading the world in its commitment to net zero emissions in healthcare. The virtue of the Greenhouse Gas Protocol is it allows us to group emissions in terms of our influence so we understand the levers for change. So scope 1, direct emissions coming from a facility from burning fuel to heat the building, for example, or release of inhaled anesthetic gases. So direct emissions are scope 1. Scope 2 is indirect, coming from the supply chain. So whether or not, is coming from electricity. So whether or not that is renewable or not affects how our calculations. And scope 3 is everything else, most notably the supply chain and also travel. So applying that to the US healthcare system, we see the most recent results, absolute emissions from healthcare in the US, 554 million metric tons, or 8.5% of our nation's greenhouse gases coming just from US healthcare. Emissions are on the rise. We see a slight dip in 2012 with improvements of renewable energy in our system. But overall, we're rising at a faster rate than other nations globally thus far. And as you can see, the breakdown by scopes, the vast majority of emissions are coming from scope 3, which I'll come back to in a moment. The other thing that we did in the US is we associated greenhouse gas and non-greenhouse gas emissions with disease burden and found that harm from healthcare pollution, from US healthcare pollution, is equivalent to 388,000 disability adjusted life years annually. Most of that is due to particulate matter or air pollution, and both air pollution and greenhouse gas emissions come from combustion of fossil fuels. So cleaning up our energy system is one of the most important things we can do to reduce healthcare's impacts. And then this is similar in magnitude to deaths due to medical errors, which were first reported by the Institute of Medicine in 2000. that 44 to 98,000 deaths annually were lost due to medical errors, about 10 years of life lost for each. So if you multiply by 10, you see we're in the same order of magnitude. And why that matters is that this harm from medical errors sparked the patient safety movement, that everything we do in healthcare is through the lens of patient safety. And what we're trying to say is that this problem is just as big and just as serious, and that pollution prevention is a new patient safety movement and needs to be taken as seriously. And so where those emissions come from in terms of levers of impact, about 4/5 in the US, and this is similar in other national health systems, 4/5 is coming from the supply chain. So notably pharmaceuticals, chemicals, medical devices, and food. And these are things we have direct influence over as healthcare administrators and clinicians and regulators, because we determine how resources are consumed. Manufacturers and regulators control what's embedded, what the emissions are that are embedded, what goes to marketplace. So this helps us to understand different levers of influence. And ultimately the question is, what is best practice both for patients and public health? And really there are three direct approaches to try and influence. One is reducing emissions embodied in healthcare service, so electrification of our buildings and our capital equipment, but that must be paired with cleaning up our energy sources, moving to a circular economy, reusing materials, reducing waste, resource stewardship, which could not be more clearly needed as evidenced by the pandemic. Matching supply with demand, meaning we have to address inappropriate or low value care, that care that is unwanted, unneeded, ineffective. All those things need to be addressed, and we can do it. And then moving all the way upstream to reducing the need for healthcare to begin with, health promotion, disease prevention, addressing the social determinants of health, and certainly mitigating all those causes of climate change. And ultimately value in healthcare, high values, maximizing the best benefits for patients and populations, minimizing costs, as well as environmental and social harms. Thank you very much.
Okay, thanks, Jodi. Okay, so let me get.
I think you can just share the screen.
Yes. Everyone see? Okay, great. So I'm going to talk about indicator 2.3.2, which is air conditioning benefits and harms. I'd like to acknowledge my collaborator on this, Lingji Chu, and also the International Energy Agency for providing essential unpublished data for this indicator. And so let me get right to the headline finding. Use of air conditioning averted an estimated 195,000 heat-related deaths among people 65 years or older in 2019, that's globally. However, AC also contributed to greenhouse gas emissions, air pollution, peak electricity demand, and urban heat islands. So we could see that on the one hand, indoor cooling, here represented by air conditioning, provides great benefits. On the other hand, there is significant harms. So I'll elaborate, but first let's look at this graph on the right-hand side. The blue is proportion of households with air conditioning. This is global. So you can see a steady rise. And in 2019, it was about 33%. So a third of the households in the world have air conditioning. The green up here is carbon dioxide emissions. And you can see a steady increase in carbon dioxide emissions as a result of air conditioning using more and more electricity because there being more and more air conditioning. And in 2019, it was up to about 1 gigaton or billion tons of carbon, which represents carbon dioxide, which represents about 3% of total anthropogenic CO2 emissions. Okay, so now let's take a deeper dive into some of this. Let's take a look at the bottom row first, which is world. So heat-related deaths were about 345,000. This was estimated in one of the other Lancet Countdown indicators. And note that it's just for people greater or equal to age 65 years. heat-related deaths averted by air conditioning, again, was about 195,000. So what that means is that if there had been no air conditioning in the world, there would have been roughly 540,000 heat-related deaths in people over age 65 instead of the 345,000 that actually occurred. And of course, these are estimates. And that's with a proportion of overall proportion, as I said, of 33% with air conditioning. Let's look at a few of the countries. So first, China was estimated to have 72,000 heat-related deaths, and roughly the same number of heat-related deaths averted due to the presence of air conditioning. So without air conditioning, the number of heat-related deaths would have been about double. And you can see that the proportion of households with air conditioning in China is fairly substantial. It's about 2/3. On the other hand, India is estimated to have about 46,500 heat-related deaths, but only 2,400 averted by air conditioning. And that, of course, is due to the small proportion of households with air conditioning in India, which is about 6%. And then one more example, the United States which has a very high proportion of households with air conditioning, 92%, it's estimated to have had about 20,500 heat-related deaths, but almost 48,000 heat-related deaths averted by the presence of air conditioning, meaning that if there had been no air conditioning in the United States, there would have been almost 70,000 heat-related deaths. And this is all among people over age 65. Okay, so you can see that, I mean, one of the points to take out of this is, number one, indoor cooling is very effective. But number two, there are a lot of inequities right now. There are some countries with very low prevalence of air conditioning, others with very high prevalence. And you could see how that's manifested in these numbers. Okay. So now let's go through the harms in a little more detail. Air conditioning represents 8% of global electricity consumption in 2019. I mentioned the greenhouse gas emissions, the CO2 emissions, but we also have the problem that the main refrigerant that's used in air conditioning is hydrofluorocarbons, and those are powerful greenhouse gases, it turns out, in themselves, and they often leak into the atmosphere, and that's an issue. We were able to estimate 21,000 premature deaths due to PM 2.5, that's the fine particulate matter emissions from fossil fuel powered electricity used for air conditioning in 2019. So that's global. Air conditioning is a major contributor to peak electricity demand on hot days, often contributing to more than half of the demand, and that contributes to power outages. And finally, it turns out that there's so much waste heat that goes from the inside to the outside as a result that from using air conditioning, that it could actually contribute to the urban heat island effect as much as 1 degree centigrade at nighttime. Okay, so sustainable indoor cooling is urgently needed. The IEA projects that according to a business as usual scenario, in 2050, air conditioning use will soar. Understandably, because people in India deserve to have indoor cooling, for example, and there are a lot of people in India. 16% of air conditioning will represent 16% of global electricity consumption. It will be 2 gigatons of CO2 emissions instead of the current 1 gigaton. And in addition, we have the hydrofluorocarbon emission problem, and that would represent 1 to 2 gigaton CO2 equivalents. So the goal we have before us is to make sustainable indoor cooling accessible to everyone in the world who needs it. So it needs to be accessible and also sustainable. And so this is kind of an outline of a possible way forward. First, we need energy efficient building design through strong enforced building codes. And a key element of that is to utilize lessons from traditional building designs in tropical and subtropical regions that over the period of centuries, people who lived in very hot climates, developed a lot of wisdom about how to build buildings that would remain cool, including by ways to provide shade, thermal mass, insulation, and ventilation. And that wisdom has largely been ignored for the past few decades. So, we need to return to that wisdom. We need strong weatherization programs, and that's actually a justice issue too. We need low-tech solutions. Fans are often useful, also cool roofs. We need continuous strengthening of air conditioning performance standards and mandatory labeling. So, for example, if through technology we could make air conditioning several orders of magnitude more efficient, then it's not really onerous. We solve a lot of the problems. So, air conditioning, just because it's called air conditioning, isn't bad, but in its current form, it has these major issues. The electricity that powers air conditioning needs to be zero carbon electricity. We need to regulate the use and disposal of the refrigerants, and there's progress along those lines. The Montreal Protocol Kigali Amendment aims to phase out hydrofluorocarbons, and so that needs to be actually implemented. We need to prevent leakage of refrigerants during air conditioning operation and maintenance. And not finally, but we need to recycle or destroy refrigerants at the end of life, often when air conditioners are disposed of improperly, and then the refrigerants leak out into the atmosphere. And then we need to expand urban green and blue space to cool down cities so that we need less air conditioning in the first place. So with that, I'll conclude and turn it over to Jeremy. Let's see.
Great. Thanks, Robert. I'm going to go ahead and try and share my screen. I think that's going to kick yours off.
Oh, here we go. Okay, good. So you have yours on.
Yeah.
Okay, great.
Excellent. So I'm going to give you a very brief overview of the US policy brief for the Lancet Countdown on Health and Climate Change. Oops. And I'm going to start out by highlighting the goals. The goals of the global countdown are to influence global processes, including the COP. And so the report is released every year in advance of the COP. And the goal there is to introduce health into the conversation. And it's been very successful at that over the years. The goals of the US brief are related to that, but also different. And so one of our goals is to highlight trends in data from the global report that are relevant and specific to the US. We're also interested in promoting awareness and understanding of the intersections between climate change and health for a US audience, which sometimes refracts these questions through a different set of considerations and experiences. We also are a very large country with a diverse population and a diverse set of environmental climate sensitive hazards. And so the goal of the US brief is to present findings through the lens of experience of populations in the US, and to highlight the very important, really fundamental considerations related to equity in these impacts for US populations. Next, we are very keen on advancing collaboration within the health sector around this issue in the US, and that's a major goal of our effort, is to organize that community. And then lastly, we want to promote action by policymakers that is informed by the findings from the global report and the US brief. So this year, we produced our 5th report. It presented a suite of indicators from the global report specific to the United States, and also brought in some other scientific work that was relevant to the US context. This brief represents the consensus of over 70 institutions domestically, and as I said, brings in data from the global report. The brief this year brings in emphasis on 3 climate-sensitive hazards that have plagued the United States in recent years: extreme heat, drought, and wildfires. And it calls for policymakers to make 3 commitments. One is an urgent investment in research and interventions to protect health and prioritize equity in the process. The second is to account for the health costs of fossil fuel combustion in their decision-making. And the third is to rapidly cut greenhouse gas emissions. I'm going to go into each of those briefly and then tell you a little bit about the report and the launch. So as Marina emphasized, we know from global data that health risks from extreme heat are growing, and the trend is the same in the United States. And particularly, we wanted to emphasize the impact on groups at different points in the life cycle. And this is a theme we've developed at different points in different ways over the years. The data for the US shows that we continue to see a pretty dramatic rise in exposure among people over 65 and among infants to extreme heat relative to this baseline here of, from 1986 to 2005. The second point is the droughts harm health. And this is something that a lot of people may not be as well aware of. And so we put some energy this year into clarifying the ways in which drought harms health. And those are elaborated here in this infographic. Of course, some of the impacts are mediated through extreme heat exposure, but a number of others go through pathways that are a little more indirect, including changes in water quality, changes in infectious disease exposure, and changes in infectious disease ecology associated with drought, impacts on mental health, particularly in rural communities, and then also respiratory disease impacts. And we also brought out the equity dimension, highlighting the wide range in intensity of exposure to drought across the United States, and then how drought affects different communities quite differently in its various impacts, and particularly highlighting the impact on rural and farming communities. And then lastly, we focused this year on wildfires. And of course, as you all know, wildfire seasons have been very intense of late. So we collaborated with some colleagues at Emory who developed this, this figure showing that we're seeing earlier onset of the wildfire season is becoming more intense, and that there's a clear correlation with temperature anomalies over this 20-year time series. We also emphasize in the report the fact that smoke exposure, it seems like it's a local issue, and of course it is very intense locally when these fires occur, mostly in the West, but that the smoke extends all the way over to you all in the Northeast and impacts your air quality quite adversely. And these impacts, again, are really not equitably distributed in these communities here: Black, Latino communities, American Indian communities, and low-income groups are all much more highly exposed and more adversely affected than groups. The report also developed some case studies, and I don't have a chance to go into all of the specifics here, but we explored the role of climate change in increasing risk for dengue in the United States, particularly through increasing vectorial capacity and R0. And then also drawing some analogies between the COVID pandemic, energy issues, and infrastructure challenges that we've seen, and then interactions with climate sensitive hazards, including extreme heat and wildfires, that exacerbated the impacts of those hazards at multiple points. And we experienced that definitely here in the Pacific Northwest with our extreme heat event this past summer, which was catastrophic and would have been really difficult on its own, but was that much more difficult to handle because of all of the capacity issues that we've experienced with COVID. And this is likely a glimpse of what we'll see in the future in terms of strain on the healthcare system, driven certainly by climate sensitive hazards, but also interacting with a number of other elements of social destabilization that we're seeing in the US. So our policy recommendations are to focus on adaptation through research that really gets down to local levels and thinks through how to reduce exposure, how to implement effective interventions quickly and at scale, focusing on economics and finance, and do a more comprehensive accounting of the health-related costs of fossil fuels. So taking those externalities and incorporating them into decision-making and policymaking. And then lastly, of course, an urgent focus on mitigation and an emphasis there on policies that will advance health equity rather than undermine it. We have a suite of additional resources in addition to our policy brief. We have executive summaries. We have briefs that are aimed at the general public. Both of those are in English and Spanish. We have a brief that is written specifically for health professionals, and we have a brief that focuses on the novel science that is in this year's report. We also have regional briefs that emphasize impacts for different areas of the United States. And we have a big launch event every year, and it coincides with the launch of the global report. And we really work hard with our partner Climate Nexus to bring in a diverse range of voices and perspectives and to reach a large range of communities with this launch. And so you can see here we had a really nice diverse collection of speakers at this last year's event, which was recorded, and you can access the recording and all of those other resources at this link here, lancetcountdownus.org. Thanks, and I look forward to ongoing conversation and answering your questions later in the session.
Thanks, Jeremy. Okay, so last but not least is Laura Bozzi, who's going to talk about the Connecticut report.
And also want to acknowledge my co-author, Rao, on the report that I'll talk about today. Right, so last September, the Yale Center on Climate Change and Health released the Climate Change and Health 2020 report. Rob mentioned it drew initial inspiration from the global Lancet Countdown, with as well as with a recognition that there was a gap in clear information specific to Connecticut on how climate change impacts health. The report is based on 19 indicators you can see on the right, tracking changes to the environment and health outcomes. Its purpose is to inform policymakers, health professionals, advocates, and residents about the impacts of climate change now and in the future on human health in Connecticut. Wherever possible, we've reported indicator results for each county. There are 8 counties in Connecticut. We tracked as far back as the data set would allow, in some cases to the late 1800s. Some of our indicators do already demonstrate a trend consistent with what is expected under climate change, such as increasing average temperature or rising number of heavy rainfall events. Other indicators don't yet show a trend, but scientific studies project such changes as the planet continues to warm. We also produced an issue brief series, 3 of which you see here. The issue briefs mirror the 2020 report's 4 domains, summarizing key indicator findings and extending the report to include specific policy recommendations. An important theme of the 2020 report and the issue briefs is recognition of climate change as an environmental justice issue. While climate change affects everyone, we know that some people are hit much harder. It's often called a risk amplifier or a threat multiplier. Some people are more vulnerable than others because of where they live or work, their age or race, their health condition, their socioeconomic status. These underlying drivers of vulnerability are often tied to deep and long-standing inequities, which are now made worse by climate change. Our issue briefs in particular elevate policy solutions that apply a justice or an equity lens in response. I'll now turn to some examples of our indicators following the report's four domains, beginning with temperature. Annual average temperature has increased over 3 degrees Fahrenheit across Connecticut and in each county in the last 125 years. Over that time, 6 of the hottest years in Connecticut have been since 2005. Of course, this has very broad implications for health, among other impacts. High heat days cause heat stress, heat stroke, and even death. High heat days often coincide with ozone alert days because high temperatures magnify ozone pollution levels. Warmer winter temperatures that we're seeing now and here in Connecticut this year can create conditions for larger tick and mosquito populations that are active over a greater proportion of the year, a longer season for ragweed pollen, which causes hay fever and exacerbates asthma. In particular, in heat-related illness, we tracked reported cases of heat stress in Connecticut and found that from 2007 to 2016, there are on average 422 emergency department visits and 45 hospitalizations per year for heat stress, though this is certainly an underestimate. Young adults were more likely to be admitted to the ED for heat-related illness than other age groups, but the risk of inpatient admission increases with age and is highest for those 75 and older. Heat risks can be compounded due to the urban heat island effect. As you can see on the right, that cities are hotter than the surrounding area because of more man-made infrastructure that absorbs heat, as well as air conditioning, as Dr. DeBrow mentioned. This health risk is magnified for those with low financial or social resources to adapt. And importantly, vulnerability factors are cumulative. Some people are associated with a number of the categories that are on the left, which puts them at even greater risk. As we look to the future, the Governor's Council on Climate Change reported projected 5-degree Fahrenheit increase in average temperature by 2050 in Connecticut compared to a 1970 to 1999 reference period. So we can expect more extreme heat events for them to become more common and more severe and to last longer. Importantly, temperature increases after 2050 depend on how quickly we stop emitting greenhouse gases. And as the Governor's Council on Climate Change said, coordinated mitigation now means it is more likely that temperatures will stabilize after 2050, if not warming is likely to accelerate. Moving to extreme events. We tracked national or federally declared weather disasters that were issued for Connecticut and found that from 2010 to 2019, there were 9 such disaster declarations, compared to only 13 in the previous 56 years. In addition to direct health impacts from weather disasters, there are important indirect effects, including disruptions that can occur to critical infrastructure, such as electricity, drinking water, food refrigeration, phone and internet service, transportation. As one implication of health, losing electricity can be life-threatening for someone who uses home dialysis. There are mental health impacts from the trauma of disasters and their long-term community impacts. In the building stock in lower-income communities, there's often at increased risk for damage by natural disasters, partly because of historic patterns of development in vulnerable areas, plus a chronic underinvestment in public infrastructure. Onto infectious diseases. We tracked Lyme disease cases in Connecticut and found that the number of cases in the last decade or so have decreased statewide, which is good news. However, there are emerging concerns. One issue we highlighted in the report is the expansion of the Lone Star tick in Connecticut. Lone Star ticks transmit a number of diseases and medical conditions that you can see on the slide. It's the most common human biting tick in the southeastern US. It's expanding into Connecticut, likely due to factors including warming temperatures and especially warmer winters. Importantly, established breeding populations were discovered in Fairfield County in 2018, and New Haven County, where we are today, in 2019, meaning that ticks aren't transient but established here. Finally, air quality. You may be aware that Connecticut has issues with ground level ozone pollution, which is a strong lung irritant. In fact, the American Lung Association gave each county in Connecticut an F grade for ozone pollution in its 2019 report. And as you can see from this figure, we found that while the number of air quality alert days for ozone have decreased over time, that more still needs to be done. Ground level ozone is largely the result of burning fossil fuels, whether in our vehicles or power plants or our homes. So this is where we can see the strong health benefit of climate mitigation, as other speakers have mentioned. Switching to clean energy sources also reduces these drivers of global air pollution. And on that note, I'll conclude with our systems level recommendations that we have in the report. I invite you to read the report to learn more about those, but I'll conclude with our overarching recommendation for swift action to reduce and eliminate greenhouse gas emissions in Connecticut for our health today and for the future.
Hey, thanks, Laura. I think we could end it here. Thanks to all the speakers, and thanks to everyone who attended, and have a good day.
Thank you, everyone.